Hi, welcome to this case discussion. My name is Lusana Schutz. I'm a clinical instructor at Stanford University, and I will be guiding you through this case discussion on no mystery. It's seizure, because it's right there in the beginning. Okay, we'll get started with the first video clip.
This lady fainted and is altered. What are we looking for?
Normal sinus. She's not having an MI.
Think about the differential. No ectopy. QT interval is not prolonged. QR restoration is 0.10.
Normal.
Pupils equal and reactive. What's the common final pathway in syncope?
Low blood pressure. I don't hear a murmur.
No. It's the lack of vital nutrient delivery to the brainstem reticular activating system.
Which is usually caused by low blood pressure.
Or hypoxia, or hypoglycemia. Abdomen is soft and non-tender.
Okay, so in this first video, you see a couple doctors at bedside of the patient. We don't see them actually first walk up and approach the patient. So my first question for you is, how would you approach this patient? What would you first look at and do? So my first question is approach to that patient. Second, do you think this patient is sick or not sick? You've just seen them for a moment and you've heard them discussing her briefly. But what's your first initial thought? Sick or not? Next, you see this patient, but you don't see any family with her and they don't really know what is going on yet. So what is a way, if this patient is not talking to you, that you might be able to get history for this patient? Because it's very important to understand her medical problems, etc. So how to obtain history. Next, I just want you to think of what are the next things you're going to do. You're seeing a video of this kind of initial approach and evaluation of the patient. What's your next step? We'll move on to the next video.
So what are we ordering, kids?
CBC, lights, head CT.
And a urine tox screen. And call a family member to verify she's not on any meds. What medications cause orthostatic hypertension?
Antihypertensives. Beta blockers, diuretics, phenothiazines, nitrates, antidysrhythmics, antidepressants, alcohol, and cocaine.
Here you see the two physicians that are taking care of this patient, kind of discussing their thoughts while they're evaluating the patient. They already are talking about the things they want to order on this patient. They mentioned a couple of things. First, you see them with an EKG. They're talking about some labs, and I think she discusses a head CT. What are some other things that you would order on this patient? So think about that. And so essentially decide, besides what these physicians are doing, how you would go about working up this patient.
What happened? Where's my daughter?
Your daughter's with your neighbor. My name is Dr. Pratt. You fainted at home, but all your tests look good. We checked your heart, your lungs, and your brain. You're not anemic or dehydrated, and all your electrolytes are normal.
I feel fine.
Are you taking any medications?
No,
Could be anything over the counter, diet pills, cold medicine.
nothing.
You ever have any heart problems, palpitations, shortness of breath?
I'm healthy.
Anyone in your family ever have seizures?
I did when I was a kid, but I grew out of them.
How long ago was your last one?
I don't know, years and years. I was on phenobarb until, like, 5th grade. They said I had epilepsy. But when I stopped the medicine, they went away. I never had another one. That was almost 20 years ago.
Dr. Pratt, can I see you for a second?
Yep, just give me a minute.
Can I go home now?
I need you now.
All right, I'll be right back.
Okay, I have a baby at home.
I just need to run a few more tests, okay? Yeah. What's up?
In this video, the physician's been at bedside with this patient and she seems to come to. He's obtaining some history and probably will redo another physical exam now that she is awake. What are some things that you might find on physical exam, both when she's unconscious and awake, that may suggest that this patient had a seizure? So physical exam findings consistent with seizure. Also, what are some symptoms as well that she may have made describe in her history that are suggestive of seizure?
What's going on with Hollies and 2?
Cardiology is supposed to come get him an hour ago.
Call them again. What about Don, exam 3?
Some sort of recurrent seizure disorder. I'm waiting on an EEG.
They can do that upstairs after she's admitted. We need to free up some beds.
Medicine won't take her.
Why not neurology?
They don't think she had a seizure.
Was there witness tonic-clonic activity?
Not really.
Did she bite her tongue?
No,
Was there urinary incontinence?
I don't think so.
Then she didn't have a seizure. Discharge her and she can have an outpatient EEG.
If she passes out again, she could hurt herself.
So send in a DMV card.
There's also a baby at home who could get hurt. Look, she had a syncopal episode, and I'm gonna rule her out for MI. So while we wait for the 6-hour troponin, might as well throw on the EEG.
In this video clip, the physician taking care of the patient is talking to his colleague about what they should do with the patient. Do you feel this patient needs further workup? And if so, what studies would you order? What could happen if this patient went home without any further workup? So I want you to think about, at this point, what would any further workup be, and do you think it's necessary?
All the tests look good, but we'd like to figure out why she had a seizure.
Yeah, I thought that was something she outgrew as a kid.
Maybe totally unrelated. Here we go.
What's all of that?
We're doing an EEG to monitor electrical brain activity. It takes several hours, some of which is done while sleeping.
Can I stay with her?
Sure, just try not to wake her up. We're more likely to pick up the seizures when she's asleep.
Thank you. You hear that? We gotta let your mama sleep.
Dr. Pratt, your patient's seizing again.
All right, Frank Kovash. I knew it.
Pulse ox 97.
Up the nasal oxygen to 5 liters.
What's happening to her?
Malik, another two of Ativan, mix up Dilan. She's gonna be okay. Just give the medicine a chance to work.
How long has she been seizing?
Just stepped off for a second. It's okay. It's okay, Jordan. It's okay. You're okay.
Caught the seizure on the EEG.
Is this just gonna keep happening?
She needs to go on an anticonvulsant medication, but after that, everything should be fine.
See any spikes? Not yet.
Can she hear me?
Sure, you can talk to her, but she's not gonna be awake for a while.
Hey, sweetie. It's me. I'm here with Caroline. Everything's gonna be okay. You're doing good.
Dr. Pratt, I'll be right back. She's gonna be fine. Looks like neurology can't refuse to admit it now.
That's our last video of this case, but a very important one. So my next question to you is, when this patient starts having this seizure activity again, what is your approach to this patient? What are the steps that you need to take to treat this patient appropriately? And what are your goals in seizure management? Next, what other medications? You heard them calling out for a couple of medications, Ativan and phenytoin or Dilantin. What are some other medications that you could use? And then very importantly, what if this patient did not have IV access? How could you stop the seizure? What would you do at that time? All right, so you have a number of really great questions in this interesting case to work on, and we will see you back for the next video and discussion of the possible answers that you may have.